Tēnā koutou katoa and welcome to this HINS webinar. I'm Rebecca Macbeth, I'm the media editor at HINS and I'll be your facilitator today. I'd like to thank InterSystems for sponsoring this webinar and making it possible. So the topic today is AI in health, transforming workflow and supporting the workforce. And I have an excellent panel joining me. I'll ask each of them to just briefly introduce themselves. So first up we have Andrew Gilbert. Welcome, Andrew.
Good afternoon, everyone. Yes, my name's Andrew Gilbert. I'm Director of Delivery and Operations for HealthX at Health New Zealand.
Kia ora, thanks, Andrew. And Dr. Emmeline Ramos.
Thank you, Rebecca. My name's Emmeline Ramos. I am the Physician Executive for InterSystems Asia Pacific.
Thank you. And Anna Campbell.
Kia ora koutou, ko Anna Campbell taku ingoa. I'm the Chief Support Services Officer for Whakarangarau Aotearoa.
Kia ora, and Troy Baker.
Kia ora koutou, ko Troy Baker toku ingoa, and I'm with Hawara Māori Services within Te Whatu Ora as a Senior ICT Service Specialist.
Great. So each panelist will give a presentation, then I will open up the floor for questions. But first, we are going to pass over to Andrew for our opening presentation, and we will come back to the Q&A at the end, so make sure you keep those questions coming in. Take it away, Andrew.
Thank you, Rebecca. Well, thank you, everybody. It's a pleasure to be here and to be able to talk about HealthX. I'll take the next 5 or 6 minutes just to walk through what HealthX is and the journey that we've been on. So what is HealthX? So August last year, we were presented an opportunity through Health New Zealand to re-look at some key and critical problems that have been facing the organisation around relieving work pressures, improving access to communities and reduce system inefficiencies. And so we came up with the concept of HealthX, which is our national program for identifying, evaluating and delivering AI solutions and innovations to the clinical frontline. The key thing is that we are focused around being clinically led, driven by safety, but also delivery focused. Who are we? We're a small national team that is sort of tasked with finding real problems to solve, assessing solutions to those problems, and putting them through a robust series of triage and clinical checks and verifications to make sure it's fit for purpose. That includes cybersecurity, privacy, safety, governance and controls to ensure that they fit for purpose. And then when they're through that process, look at scaling as best we can throughout the organisation, both thinking rurally and district, regional and national. The key, returning to the key point, is always referring back to relieving workforce pressure and driving access to remote and rural communities. We always have a sort of an eye on the future. So the current horizon is a sort of an immediate 0 to 6 month timeframe, what we're doing right now, and what we're getting out the door. Where the sort of future horizon 2 comes from is what's working, what's been proven elsewhere, what's that sort of like next phase, which is the 6 to 12 month area. The longer term horizon is a little bit more explorative, and we've got partnerships out with the universities, with MedTech IQ. We also have relationships with the NHS to look at what early signs are out there and internationally, and how can New Zealand benefit from these innovations. And we've got examples of bringing those into Health New Zealand through those pathways. So where the rubber hits the road, we've had a discipline of releasing an initiative a month over the last 8 to 9 months that we've been in operation. There's a few examples on the page that I won't go through all. Some have been in operation for a little while, and some are very close to getting released. A couple of good examples around reduced administration with Copilot, and also the AI scribe innovation and the delivery through EDs nationally. Recently was on PVNZ this week. Is a bit of a shout out to the work that has been completed, and it's been very encouraging results, resulting in reduced cognitive load for clinicians and actually releasing a little bit of stress around the amount of administration work that needs to be completed. So where the benefit really lands, we're seeing a constant or a consistent reduction in admin and releasing more time for clinicians to spend time on with patients, and or administrative teams having less cognitive load to work through. We are looking to expand in some areas, and we're proving that it's been quite an effective journey. But just where we're going to land, just as by way of summary, we are preparing our New Zealand clinicians to use AI tools with confidence. We do have a national safe pathway to bring things through to scale. There is an independent governance board, the NIAG, to review, screen, and assess these tools. And then it's about moving AI into the workforce in a safe and clear manner. Thank you. I can now hand over to Emily.
Thanks very much, Andrew. So I've got a couple of slides I'd like to go through. I was thinking the other day about the information that clinicians need in order to do the job, and one of the main things, particularly doctors do, is to put together a diagnosis. We call it a differential diagnosis, which is a list of things that could be wrong with your patient, especially when you first meet them. I was reminded of this really old paper from 1975, because it helped popularize a teaching that many of us heard at medical school, in that if you take the patient history properly, you would probably arrive at the right diagnosis about 8 times out of 10. And then the other 10% is come from the information that you gather when you examine a patient, and the other 10% will be from the investigations that you order. The exact numbers are dependent on the actual setting, but the principle is there, and it that story just means that the patient's history, the patient's story really matters, and the information that you gather when you talk to the patient or when you first read that referral letter is really important. Now, what has changed since the 1970s is that the patient story is now actually a lot harder to see, because it's fragmented across the referrals, across in sometimes quite bloated clinical notes, because occasionally we do copy and paste information from one source to the other, previous pathology and imaging and medication lists, discharge summaries, and handover notes. And now it's becoming more and more popular for clinicians to review and accept patient messages across something like a patient portal. So I guess for me, the question of how can we help clinicians with this wonderful new tool that we have in generative AI. One of the most practical roles for that tool, of course, is to help clinicians recover the story from all the noise, hopefully right inside the workflow where they're doing their work, so they can make better decisions with a lot less cognitive burden. So I've just got another slide here that says, I think AI should change the shape of clinical work and make it less about manual data entry, and less about searching through a lot of fragmented information that we currently have, but help surface relevant context at the point that clinicians need that kind of information. I think more and more we are expecting clinical staff to manually enter data, because we do need to capture a lot of this information. And I guess in the past, we used to have to enter information to help with clinical care, but now more and more we're expecting clinicians to manually enter data because we need it for coding or we need it for reimbursement or we need it for statistics or we need it for statutory reporting. But I do think now that we have this tool that can help, produce a draft of clinical notes to help summarize and in some ways to automate this idea of data capture. We're not quite there yet, but I would see AI helping with earlier risk detection and prioritization. We do have to go about this carefully because, we do know that artificial intelligence does tend to hallucinate. But more and more, I think it is less about capturing data and, decision support coming up because of automated data capture, but more about background intelligence in that it actually will surface for the clinician patients that are at risk of deterioration and help them prioritize who they need to see soon. And again, over time, I think we will be using artificial intelligence for, seeing who is getting best practice care and which of our patients are actually adhering to a specific best practice clinical pathway. But before we get there, I think, I'm really excited. I'm super excited about generative AI and its potential. But we do have to see it as, at the surface, it is just another tool that we can use to help clinicians. And I guess what I am seeing in some ways is that people tend to pick the tool that, the question tends to be what AI tool should we deploy, but actually the question should be, what care delivery problem are we trying to solve, and then pick a tool that best fit the solution to that problem. It's less about, which AI model should we use or which tool performs well, but more about, can the service safely use it? Because we do have these solutions that are quite fragmented across a clinical workflow, and the opinion that I hear from all the clinicians that I work with, our customer sites, is, we just want to get on with it, and we don't want something that we're going to log into again and again. We want a tool that actually works within our workflow, and we don't have to look for it, and we don't have to use multiple applications. Of course, this idea that will clinicians adopt it or use it is important, but we also have to look at how do we design that workflow so that it fits the workflow of a nurse on the ward or a doctor in an outpatient clinic. We really need to look at these problems alongside the tool that we're picking. And I think the last bit is around pilots, because I see a lot of pilots all over the place with lots of very exciting tools. But we do need to think about, once that pilot is over, is this piece of AI something that we can govern and we can scale across, not just the group of willing and enthusiastic and potentially technology literate people that put their hand up for the pilot, but can we use it across, for example, a pediatrician who is very experienced but a bit less health literate. So I think we need to think about the fact that the unit of transformation is less about the model, less about the AI tool, but about the workflow itself and about the human that is really keen on using it, but may not be as capable as we want them to be. Thanks very much. I'll pass over to Anna.
Kia ora koutou. So I work for Whakarongoto Aotearoa. We're a digital health and wellbeing triage and navigation provider across health and social sectors. To set the scale, we have around 7,000 moments a day where someone decided to reach out to us for help with their health rather than going it alone. And we deliver that across 35 plus services in terms of clinical triage, mental health and addiction and emergency triage and more. And for many communities, it's not the supplementary option, it's the only option that they have to access their path to wellbeing. And I guess I wanted to start the time with you today with something that we say to each other internally all the time. For every person on the other end of the line, this might be the most important call, text, web chat that they make today, and it may be the hardest day of their life. Every one of those interactions is a person, and it's a person who is looking for health and support in their wellbeing journey. And so for us, working in a digital capacity to be able to help those people is really critically important. As everything that I share today comes from that reality, a live national service where if we get it wrong, it has consequences. And so we need to think really carefully about what we do and move at pace in a really safe way. And over the last 10 years, we've had 20 million health journeys, and it's really want to emphasise today that those are held together with a really strong governance framework. And I guess I'd get you to hold on to that word because that word governance will come back. It's a really important theme for us. And I guess that gives you a sense of the scale for us. Really, it's the pressure underneath it. And I'm sure that in all of your roles, you're feeling this as well. And it's the pressure beneath that volume and what it does to the people who are delivering that mahi. So while our volume continues to increase, the real challenge for us is the number of people that are at significant risk of harm to themselves. Those risks have grown well over 150% since 2019, the number of people who are at great risk. And as a result of that, every one of the interactions in the mental health space particularly are taking twice as long, and the people who are contacting us have a much greater need for care. So that creates a real sense of pressure for our team. And so as an organisation, we've really taken the stance of how do we help those helpers so that we can use technology in a way to help them do their job really well and do the things that they turn up every day to do so well, which is provide that clinical expertise and human connection, and how do we enhance that using technology. We've used lots of different tools. I've chosen just to focus on two today and actually more on the themes of the things that we've learnt. But we've been very deliberate about the work that we've done in this space and tried to move at pace with strong governance and strong safety at all times. So the two that I'll talk to you about today is auto summary, which really drafts the summary of a call for our people. And the second is a conversational AI that we have built for our text and web chat services. I'm probably going to focus more on welcome. Interestingly, if you know, one of our key success measures that we've put in place as an organisation for any initiative that we're doing using AI is learning how to use AI with our team, and governance is a critical theme that really connects that across. So I guess the number of the problem is that we've got people on the front line who are holding a crisis conversation. And at the same time that they're doing that, they're also running a clinical assessment, they're documenting across several systems. It's definitely not admin. It's reasoning safety, planned triage outcomes, and getting it wrong has real consequences. And so our team feel this really heavily every day. And we found using tools to try and support them to take some of that cognitive load away was a really good way to do that. But interestingly, averages are really misleading. And so what we found with auto summary is that it works for some people, it doesn't work for everyone. And a key learning for us is that I think taking a general approach to tools doesn't lead to the same sort of success as if we really start to work with specific teams about their specific problem and try and solve that together. And I guess that's where our welcome tool came in. So welcome is applied in our mental health and addictions lines, and in our web chat and SMS areas. And really, it stems from the problem that every time one of our counsellors picks up a contact, they don't have visibility and they don't know if it's a routine inquiry or it's the most important contact that someone has made that day. And they carry that weight on every single contact. And really importantly, we as an organisation also know that that person who's taken that huge step to reach out for help and is seeking that help has a wait until they connect in with a person who can help them. And we want to be able to start every one of those interactions and be able to help straight away when that person gets to us. And that's where Welcome comes along. So it's a tool that's designed to collect information from someone who contacts us, but really importantly, to hold them in that transition time until they can connect to one of our humans. And so the idea with Welcome is using technology in a non-clinical capacity to support someone in that wait period so that we don't lose them in that moment of real need when they've reached out to us. Really critically, it does that groundwork, it greets people, it's honest from the start that it's AI, it gathers context quickly, the boundaries are really firm. Welcome doesn't diagnose, it doesn't treat, it doesn't counsel, but it just holds people warmly while they wait. No one's words who contacted us were used to train this model, but the clinical direction came really clearly right from the start from an independent clinical governance group, and then working with our trained experts within the organisation right from the start, because it was their problem to solve, and we worked with them the whole way through while we developed and created this tool. I think the things that I'd really like to highlight for us that made the biggest difference in terms of creating tools that work well for our team fall into some key themes. So the first is transparency from day one. We have a principle of doing work with our team, not to our team. So to do that, we understand the issues that they're trying to solve and then work with them to make sure they're part of the design, they understand how the tools work, and we're solving a real problem that they want to solve with us. That brings people along, and it creates the situation of the second theme here, which is champions, not mandates. So we're really not after compliance. We're after buy-in, and we're after people who believe in the tools and who bring their team members along and that care enough that they would surface safety signals that may have been buried if we mandate things. So a really key lesson is about making sure that we bring our people along with us, and that they understand how things work and that they feel a real sense of ownership for the tools that we're creating and the problems that we're collectively solving. And that takes us to this third theme as well, that doing those things helps us to frame it with the team that we're here to support them to be more human in their interactions in the moments that matter in a human-to-human relationship. So using tools to support and augment the mahi that they do every day. So our goals are very clearly articulated around unlocking capacity, supporting our people to be even better at the amazing contribution that they make every day, and to try and deload some of that pressure that they feel every day on every interaction because of who they are and the type of work that they do and the mission that they have to try and bring wellbeing to everyone in Aotearoa. So I think the three principles that really travel for organisations that are thinking about AI and come from some of the lessons that we've learned is really, like I said, working with a team to understand the problem, trying to collectively solve that problem, and realising that averages serve no one. So, for example, our teams in mental health had really good results with the auto summary. Our teams in the health area who have a much quicker triage and a different sort of interaction with someone didn't see the same success. And that's okay. That is success. Finding tools that work for one group is success. It doesn't have to be right across the board, but really getting clear on which problems you're trying to solve and when. The second is that governance really supports innovation and enables it. And so designing strong governance right from the start is a really critical step when you think about anything to do with AI and putting it into your business. First of all, people appreciate the tools and will use them if they know how decisions are made, that clinical safety is at the forefront of everything that you do, that the privacy requirements are thought of up front, and that we're really clear on what we stand for, what we will do, what we won't do, and what our principles are. It really helps to build trust and build engagement and build momentum. It's worth putting the mahi into the governance structures up front because actually it accelerates your innovation pathway. And it makes sure that as you innovate, you're keeping true to the things that you have committed to do with that AI. And most importantly, you're keeping your team and you're keeping the people contacting your services safe and confident throughout that interaction as well. And then the third principle for us clearly is that equity is something that we must build in from the start in anything to do with digital transformation, particularly AI. It's architectural, it's not aspirational. So if we neglect building equity into our thinking right from the start by using the voices of people with lived experience, by really thinking about who has access and are we negatively impacting that accidentally through this process, then we're going to build inequity in its scale. And actually, it's our job as we're going through and creating these tools that we are centering the architecture on equity and bringing every person who should have access to services with us through the journey of inputting AI, not accidentally leaving populations behind. So honestly, I think in closing, there's a tension between innovating at pace and doing that really safely. And we're really very comfortable with that tension. And the other part of the tension is that no tool is ever going to be a perfect solution. AI keeps moving really, really, really fast, much faster than people can keep up with that. So none of this change is really a technology change. It is all people change. It's getting people to do things differently than they have in the past. So for us as an organisation, safety governance is non-negotiable. That's an absolutely critical part of our path. We've chosen to go with best fit over perfection. So we study, we learn, we set up our criteria, we set up our non-negotiables, and then we start. And we do that in a thoughtfully governed and safe way with our team, rather than waiting for the ideal and knowing that things will change and evolve as we go on. And like I said at the start, one of our key success criteria is that we are learning to use AI successfully, safely, in a well-governed way with our team so that we're equipping ourselves for the future as well as today. Because behind every single one of those 20 million journeys is a person with a whānau who's reached out for help, and we can't afford to wait to be perfect because they need us to be able to answer their need in that moment now, and they need us to answer it well and safely and today. So it's really important that we think innovatively about how we can use digital tools to enhance that human interaction in every way that we can. I'm really keen in the Q&A to hear where you're all at in that. But before we get to Q&A, I will now hand over to my friend to speak about ProPilot.
Kia ora koutou. Relax, get comfortable, and all the tough kōreros already happened before me. I just want to acknowledge Rebecca and Will for inviting me into this space and doing all the behind the scenes. And I want to acknowledge the three speakers before me, especially Andrew Gilbert, HealthX. He's the guy that gave me the first lot of licenses and started my journey in enabling Copilot. Copilot, and the reason I changed it to ProPilot was exactly that. People are in the height of trying to understand AI, trying to be the champions of AI without really getting practical use of it. And I wanted to attract those that were falling through the system. Like for myself personally, I attended a few trainings and it never engaged with me. I didn't see myself in it. So I thought I'd come up with something to help our whānau that were feeling the same way. So for a bit of fun, I put Bro and Copilot together. And I wanted to shift into a space of enabling tino rangatiratanga in tech. Because I think it's important that we start shifting and moving away from theming into functionalizing and enabling. And a lot of people ask me around the essence of tikanga and equity and all those wonderful things that we keep talking about. My whakaaro is this: I'm a Māori and I live in Te Ao Māori every single day. So that's the core of who I am and the kaupapa. So any technology is an enhancement of that rather than the other way around, and just setting the scene of If I'm not in a place where see myself or feel myself adding value to the kaupapa, I find a newer horizon and environment. So again, mihi to you, Andrew, for bringing me into this space. So the first place that I talk about, people are talking about productivity and efficiency. Productivity and efficiency is at the top of scope of everyone. Where I see productivity is people. Have you heard the saying, have you had a productive day? So I think a huge part of that is having clarity around their role. So one of the first uses when I started up BroPilot was a drop-in session. So I have a drop-in session every Monday and Wednesday, and everyone can come in organically themselves with real use cases, and we whariki and we whakawhangangatanga and talk over it, and they leave with a product, and a lot of us are well more informed. Where I get people to start off with is their PDs. If you can't understand your singular role and not have clarity around what your KPIs are, where are the gaps of understanding, and I see capability as a big part of utilization of AI. So if you haven't already started a coaching and development plan with AI and growth in there, you should start. The biggest risk I find, whānau, is if we're not clear within our own role, then we've got a rōpū that may not be clear. So the immediate action is to get clarification around what your role is and start really embedding feedback and opportunities of saying, hey, I've tried this, and always run it past your manager. I've got a thing called Chase Your Manager. And getting back to tino rangatiratanga, it's about succession planning. So my whole concept is to make sure that you are being the best that you possibly can be in that space. People are getting disorientated and reading a lot of reviews. I'm really getting people to look within themselves, what can be immediately used right now, and something to grow towards. So clarity, capability, and when we talk about innovation, one of the things I love to talk about is execution or excellence. Be the best at it of what you've already got, rather than always chasing something that you've got to apply for or adopt. So to make things a little bit easier to explain is I created an acronym around the 2 points of differences. So EA being more around, are you reacting to AI or are you responsive? So in terms of the reaction, and just to go over a few, so ad hoc, pushed, tool first thinking. We've got an amazing opportunity, especially with these being able to build your own agents in the suite of some of the tools, is you've been able to tailor a tool that works best for you, but looking at a real foundation of experts by YouTube getting fragmented experimentation. So not really getting a real source of truth of understanding. So rather than trying to keep up with where you think you should be, actually being toe and noa in where you are, and start bringing things in that will be useful as you start growing alongside it. If you are starting new, baselining your organization. So do a real good baseline and see where whānau's appetite is, because what I found getting the most traction is the early adopters. In my community, we call ourselves the Haututu. Haututu is not afraid to try new things, to get involved, to roll your sleeves up. So that's where the innovation comes from. We're willing to give this a go and a try, and we're not afraid to fail. Now, let's not be silly. I'm not saying anything risk or failure in this industry. Failing, we've tried something, it hasn't produced something, but being part on the journey. Culture of self-development, and from the culture of self-development, I think it's really important that every single person is trying to be the best version of themselves in building networks. It's amazing when you get a group of 50 people on the same kaupapa, they start sharing all these different ideas, and we're all going to go away with an element out of the 20. We may apply 2 things that we'll try, but we know what the other 18 will swing around back for. Really, really encouraging people to be proactive, to take your time with it, to look ahead and saying, cool, what are we happy to try now? What are we happy to have in different paths? And sometimes in your organization, you've got multiple pathways or multiple ara. So our whānau that are slow burners, building some robust ways of engagement and trust, while the early adopters will start paving the way moving forward without us all fully being left behind. Continuous improvement or continuous learning is really, really important, and capability uplift. So stop wasting time being distracted, drive enablement within yourself to grow your organization. That's what we really need to do it. So capability uplift comes out from the results. So I was in a cultural setting. I was whāngai. I was raised by my grandparents in the early years. So I've adopted this in regards to how we adopt AI and use. So if you look for perfection, if you look for imperfections, you'll find them always. You'll keep finding them until they're all aiming to be perfect. But if you want to look for potential, you'll find that too. So it all depends on your ahua, your wairua, and your forecasting of how is this going to benefit our whānau. And that clarity element is you'll start identifying all the grey matter and start shifting that out. Because for us in Te Ao Māori especially, we're more lethal kanuhi ki te kanuhi. That's the real whakawhangangatanga, the kōrero of understanding. And if we can start reducing, but without reducing the quality of the information that we're doing. So machine learning works alongside you, and I'll always incorporate Te Ao Māori in all of my prompts, and every single time I use the lens. You've got to be patient. Like when I was a pepe, my grandparents were patient when they taught me things. So you got to be patient. It's not going to come back always perfect. So you look at reiterating. So you don't, instead of blaming your golf clubs or your fishing rod, don't blame the tool. Look at how can I prompt better? What am I doing differently? Because if you're going in with a perfection mindset and saying, I've got it absolutely right, you'll find you don't. Learn and grow together your algorithm. So he huarahi matauranga tawa is like we're learning and growing together, which is your algorithm. You're the decision maker, so you don't shift. You carry the mana and the responsibility of everything you do. So you can't go blaming a calculator. You can't go blaming an AI. It's your role to make sure that it's tika and pono always. But you've chosen to use a tool to do that. So don't abdicate your responsibility. And I named it Coco because of Copilot. And if you look at Coco, you'll see 9 fingers. So I've left all the imperfections in there. But the most important thing I want to end on is that Coco is a culture. BroPilot was a culture of use, not being afraid, whakawhangangatanga, and talking about scaling up. I didn't have to. You got one down in Taranaki that's encouraging a whole group of people to come in. So building those champions, and a lot of our whānau that started off resistant are now Python coding and creating agents and doing some amazing sorts of things. So my focus has been the kore te rua, the 0 to 2, and whānau that are quite slow in the uptake. But the one point of difference that I'll make across anyone else, I let everyone in a home maru, in a safe space, bring out all their kōrero, no matter how ugly it was, what their concerns were, so that we can go right down to the root of the concerns, and then we can whakanoa that with open, robust kōrero, and people left with a element of what they could do moving forward. So don't be afraid if you haven't started. And the last bit of advice, unlock your ngaka, your heart, and let that hautatu that stopped believing, that stopped researching, that stopped trying different things, and get curious. This is the best time for it. Mauri ora whānau.
Kia ora, Troy. Well, what an excellent set of presentations there, and we've had lots of questions come in. The first one on the list is about the data. So AI obviously needs data, and with many places still using paper-based records and collation, would it be better return on investment to ensure all patient records are recorded electronically from the start, so you can add the AI layer over top? Perhaps Andrew or Emmeline might be able to talk to that need for electronic data collection.
I think it has to be done in parallel. I think that digitizing records, I think, is probably going to improve the AI quality, but delaying getting started to do that would delay the benefit and the learning. So I think a bit of a Switzerland answer would be to actually try and do both in parallel, and then and grow that digital content and the paper records.
Yeah, I would agree with that, Andrew. And actually, we I was in Indonesia last week visiting a customer who is coming from paper to a digital EMR, so they're transitioning. And they're not shy about starting off with something that's AI enabled. Because I think it's a bit of a chicken and egg situation, right? If you don't have the data, then you can't use the AI. And in some ways, that's true. But if you use the AI to capture that data, and if you have, for example, an AI-enabled EMR that can turn some of that unstructured data into structured data, and then it's almost like a virtual cycle. Then you can use the AI to capture that data, turn it into structured data, which clinicians hate coding. So I know that for a fact. But you can then very quickly gather a set of data that the AI can use further, providing that, of course, the data is captured accurately and appropriately, and you've got a human in the loop to make sure that you don't perpetuate any hallucinations that might have been captured in the first place.
What about any thoughts about, there's been a lot of chat online about the risk of degradation of skills through over-reliance on AI. Somebody's asked about, any thoughts about how to mitigate that?
Yeah, that's an interesting one, Rebecca, and I am seeing that in some of the literature and some of the people I talk to. I think when I was still practicing, of course, it was ingrained in me that you have to do your history taking properly, and you have to examine people clinically properly, and I think in some ways, if you have that basic training, and you have the basics of doing your history and examination and your assessment and putting together your plan, I think these first principles and basic skills will set you up for the future. But we're now seeing more and more, instead of actually examining people, we scan them, we x-ray them, we image them, and we now have these fancy digital stethoscopes, whereas in the past you used to have to put up with a manual one. So yes, I would agree that in some ways some clinical skills will be degraded, but it will be replaced by, I think, in some ways, skills and technology that are far more accurate and are far easier to use than manual. It's a bit like the argument for the calculator, right? Everybody uses calculators now, but you still have some people who can solve arithmetic problems longhand. But do we actually really need to?
I think if I could add to that as well, I think it depends how you think about the way that you're deploying AI, and if you're really focused in on enhancing human capacity and helping people have the space to operate absolutely at the things that they are trained to excel in, then you're applying the AI in a really different way than if you're using a minimizing stance, so taking work away. I think that there's a lot of evidence around the organizations that are having the most impact with AI, the ones that are thinking about how do we reduce the cognitive load for people and enable our team to be able to do the things that only they can do, and to really emphasize and enhance that human to human connection. So, in that respect, you might be degrading capability to do work that actually doesn't matter, and enhancing someone's capability to work that really matters. And I think, that's the approach that we're trying to take.
I'll just
I
add
think
on to
another
that as well.
concern.
Sorry, Rebecca.
Go ahead.
My 5 cents worth is if you've got the culture of continuous improvement, coaching and development, that'll be picked up quite early before it becomes a problem. So you look at the quality checks on the throughputs, and having that quite strategic build-in. The other things that I'm finding too is some PDs and JDs are already dated. So it's a real good opportunity to start reviewing to make sure that you've got clear focus on the doables, the KPIs, the alignments, rather than having all that grey matter in and around it that's no longer relevant. I think that's hugely important.
And I guess another concern alongside the degradation of skills is the replacement question. Andrew, you spoke about HealthX is there to sort of amplify and enable people rather than replace them. But what does good look like, and how do you build that trust so that people do feel that the AI is going to be an assistant and enabling them as opposed to eventually taking their jobs?
Great question. Just looping back to that point around the degradation, we're also supporting research into that area as well, and that's a key piece. So I think the question is not fully known. So I just wanted to note that we're also doing a piece of research around that for clinical workflow, and with junior doctors. To answer your question, Rebecca, yes, I think from a health ex perspective, I think good means that we're looking to take routine and low value tasks off clinicians, release the burden, the administrative burden. So far, that has been the feedback so far has proven that to a certain extent, and that's been encouraging. I think that's always probably as far as we're prepared to go at this stage, and look at tools that actually provide that. When you get into other areas around diagnostics and other sort of clinical decision making, the bar is a lot higher. And those international programs and research we're doing domestically are going to be answering those questions through time. So I think specifically keeping humans in control and ensuring the AI supports and scales, but doesn't replace their judgment, whether clinically or otherwise, I think is where we're sort of putting that limit.
Great. We've got quite a few questions to get through, so I'm going to move through them reasonably fast now, so hopefully we can get to most of them. The first one at the top is another one for you, Andrew, just asking, are we looking at using Heidi for translation in the workplace? They saw some work going on in Australia at Monash, and translation costs are a huge amount of money for Health New Zealand.
I can answer directly that it's not an actual initiative at the moment, but it is an area that we're aware of our Health NZ footprint, and that it's a process that's under pressure. But currently we're not doing anything specifically, but as an area of interest, and we potentially an initiative may come out of there soon.
Is that used, Emmeline, within IntelliCare within Indonesia? Is there any translation as part of that?
That's an interesting one, Rebecca, and you know, certainly in places like Indonesia and Thailand, where IntelliCare is in hospitals where the doctors are multilingual and the patients are multilingual. You know, the doctors are used to capturing the ambient conversations either in English or Thai or Indonesian. It's a tricky one because, you know, we do know that the majority of large language models, regardless of what model it is predominantly trained on the English language. So, you know, it's and especially if you remove the human in the room, where you remove the actual translator, you know, how would the doctor know that what's being captured is actually appropriate? And you know, yeah, it's a tricky one. It is certainly being used, but yeah, I'll watch this space to see whether or not it's something that may produce, you know, a clinical safety issue in the future.
Yeah, difficult to keep the human in the loop if they can't speak the language. And how do clients feel about being greeted by an AI persona? And do you measure the incoming calls and how many are continuing?
We measure all of our interactions, and feedback is a really important part of how we shape all of our services. So that voice of people with lived experience in tangata whaiora is critical to us. We did a whole lot of research before we started this work, and we're actually really surprised with how ready tangata whaiora were to use tools. And we're expecting agentic tools in their interactions with us. So, you know, we asked them, and that's what drove this initiative. People contacting us are ready for the tools. They want them because they want to be answered, they want to be held, and they're expecting those tools. And then in our development process, we tested with people with lived experience as well, and other mental health providers as well. So, you know, key thing to take out of it, listen to the people that you're serving. They will tell you what they're ready for, and they'll tell you what they need.
Thank you. Troy, maybe I might pass this one over to you. Is how do we ensure that health tools meet the specific needs for Aotearoa New Zealand? And if you're using New Zealand health data specifically, where's it coming from, and how are health service users being informed of, yeah, I guess keeping in mind that the tools may have been trained in a different territory?
Yeah, that's a massive loaded question. There's different pathways to address most of that. In terms of data, and data sovereignty's come up quite a bit. So the tool that we're using at the moment, which is the Copilot, BroPilot suite, has got a tenant. So that's going to give you limited access, and it's protecting all of that within the whare of Te Whatu Ora in that regard. So understanding what it is and how it is part of the problem. But my major concern right now is whānau reading articles and everything and getting quite convoluted and confused by the wider scope of things. I think it's really, really important to start pragmatically working through it. And to be completely honest, I'm not in those informatic areas, so I don't want to go talking on something I don't have the subject matter expertise. Is that something that you've got there, Andrew, that you can talk to that?
I think you covered it pretty well, Troy. I think there's that safety aspect to where the data is, and what is interesting is that the underlying models are the big models are actually quite similar. So I think it's an ongoing piece that we have to be very conscious of, and being transparent around that and what is compliant or corporately approved use in tools versus what you would do in personal is quite different.
Yeah, talking about those base LLMs, the next question is, how do you manage the risks of hard baking AI tools into workflows at a time when the generative LLMs are being subsidized by the companies developing them? So I guess there's potential increases in cost. So, I'm sure you've all thought about this.
The easiest way to do it is to step out to see where, like for me, from a perspective of Te Ao Māori and holistic, the application of the rongoa is the most important thing in kanohi ki te kanohi. So if you're looking at the entry point, is there a kaitiaki or a protocol before they can enter into the entry point? Is there a minimum standard before they come in there? So what sections of that is passing data and or where you could automate it? That's why I'm going back to the responsiveness. It does take a little bit of time to actually work out where the best intersectors, and then you can harvest a lot of the data to whakamana your kaupapa. You shouldn't start any kaupapa without a data strategy. Part of that data strategy is how are we capturing it, at what pathway, what's the entry point, and the final service delivery. Because with everything in an alignment, we need to be able to whakamana the kaupapa by capturing data that's actually going to be a catalyst of behavioural change that will increase, as a byproduct, better health and equity and outcomes.
This one might be for you, Anna, I think. Given AI is known to exit the sandbox as it develops, what are the measures to stop AI chatbots in these contexts, they say, not for want of a better phrase, going rogue?
Oh, it's really critical, and this is why I talked so much about governance at the start. One of the things that we have thought about in our space is how do we audit live in the moment and make sure that we're tracking the AI and making sure, because by design our tool is non-clinical and it needs to stay within those guardrails. So thinking right from the start of your piece of work, how are we going to measure that? How are we going to make sure that it stays within the guardrails? What are we going to do if it doesn't? So, having the ability to turn that tool off or to have another tool take over it or to have a human intervene is really important. So that governance from the start, clarity about what a tool should do, clarity about what you will do if it doesn't do what you do, and clarity about how will you know that it is doing what you are doing are really critical parts of that governance journey, and really encourage you to do that right up front. And then everything you design fits that criteria that you're going to have.
And the next question is about educating our kaimahi about AI, helping them to better understand how it works, how their data is used, including the limitations of it. So they've just said this seems like a really important foundation for rolling out AI more widely, could help with generating engagement. What do you think about the general role in terms of education, and where do you start with that? Because obviously people are all starting as, I think, Emmeline, you were talking about, they're at very different levels of understanding. So yeah, I think that's relevant for all digital tools, but particularly for AI education.
The foundation of ProPilot was I had pre-surveyed everyone. What's your preferred way of learning? Because there's a whole bunch of whānau that want self-learning tools. There's a whole bunch of whānau that wants kanohi ki te kanohi and identifying the different streams, because we're all different, multiple streams, but mostly finding out what do you know about it up front, because you'll be able to address that sort of stuff as well. I honestly like to build uropu in different regions, different part of the motu, so they can start co-designing local reo and pūrākau within their design. But it's about what's the best fit for us to come together, sit down, have robust conversations, and start iteratively shifting that way, rather than whānau being overwhelmed by all this AI kōrero, and where it's going to scare them that much they won't even start their journey. So start the conversations and start pulling whānau in together and start learning iteratively together. Kia ora.
We took a very similar approach, Troy. So spoke with our people, surveyed our people, understand where they're at. Some are running, some are really conservative. Go with the willing. So we worked with the groups who were most willing and had the biggest problems to solve, and that created a pull in the organisation from other parts of the business because they saw the impact that people who were adopting the tools were having and how it was changing their world. And then we are really committed to making sure that all of our kaimahi have the skills to understand what AI is, how it works, how you keep safe. We know they're going to use it, so let's teach them how to use it safely and within the parameters that we can protect the people that are contacting us and protect our kaimahi, and noting that the learning in the space is not a course and then you're done, because what you know today is out of date tomorrow. So it's actually about fostering that learning mindset and giving people the skills to unleash their curiosity and figure out things themselves as well. So partially it's a facilitation and a direction role to teach people how to help each other. And one thing that's really worked for us as well is setting up cohorts and team groups that, man, the learning that they give each other is phenomenal and much better than probably any course we could have invested in. When someone posts something and says, oh my gosh, look at this amazing prompt I wrote. This is how I did it. This was the impact. And then everyone's learned, just from each other's amazing skills too. So multi-layered, along a long period of time.
I think, Anna, just to finish off on that one, I think that our experience was very similar, and even though it's joined learning and there's different learnings or forums that people can join, whether it's structured or drop in, it's almost your own individual aha moment when you see the value. And it's I think the trick is being able to give the opportunity for people to actually have that aha moment, whether it's a productivity tool or other. That's what I think we're striving for.
Yeah, go with the willing. I really like that, Anna, because in some ways that sort of maps to a lot of change management techniques that we like to employ at a site. So this idea that you identify a group of willing clinicians who are already a little bit health literate, and you try and get them to use the tool, and of course, most importantly, you identify clinical champions who know their organization quite well and who know their colleagues really well, and can sit side by side with somebody who may be a little bit reluctant or a little bit afraid to start using AI because it's so alien to what they do on a day-to-day basis. So yeah, wholeheartedly agree with that.
Excellent. Well, thank you everyone for joining us today, and thank you to our panel. I'm afraid we do have to wrap up. We didn't manage to get to all the questions. It generated plenty of them, but I think we've all learned a lot. So that just leaves it to me to say thank you everyone for a fascinating discussion, and mā te wā.